We're going to have each panelist introduce themselves when they approach the podium, starting with myself. I'm Luanda Grazette, Director of Advanced Heart Failure, Professor of Medicine, Miller School of Medicine. So my disclosures are this, and I'm going to begin the day by discussing, so why are we talking about a new device therapy for patients with NIA class 2 to 3 heart failure when we live in this era of unparalleled success of pharmacologic therapy in heart failure? So in 2023, we have so many highly effective therapies that sometimes we actually have a hard time getting them all on board. And this slide demonstrates that with the exception of the ACE inhibitors and the ARBs, which started it all off, each therapy that's shown a mortality benefit has been on the background of existing GDMT. And each of these therapies has demonstrated incremental benefit with MitraClip and the SGLT2 antagonist bringing up the rear most recently. So in 2023, we live in this era, we had the triple drug therapy, which lasted for about 20 years. Now we're living in the Fantastic Four generation, which is how we refer to it in the US, which kind of reveals how much time we spend thinking about Marvel movies. And I understand that in Europe, this is referred to as the pillars of heart failure medication, and you can insert your own cultural comparison, joke, and/or witticism for that. So regardless of how we call these medicines, regardless of the sobriquet, the combination of all 4 drugs is extremely potent. And in this analysis, which is a pooled analysis meant to estimate the combinatorial efficacy of different iterations of heart failure medications available currently, we can see that with the Fantastic Four, ARNI, beta blocker, MRA, and SGLT2 antagonists, there is an estimated theoretical 61% risk reduction for all-cause mortality. So that translates to about a 5-year of life gain for the average 70-year-old patient with heart failure, which is amazing when you think of where we came from in heart failure therapy. So with therapy this good, where are the remaining challenges? Well, it turns out that 4-drug therapy isn't being achieved quite as often as we would like or prefer. So this is a central illustration from a study of nearly 300,000 patients from the US, Japan, and Sweden, and progress from initiation to dose titration with follow-up at 100 days after initiation of drug and at 1 year. And if you look at the central panel, you can see that with the US on the end, at 100 days, about 10% of patients aren't on any heart failure medications at all, which is striking. If you look at Sweden and Japan, they do slightly better than we do, but still nowhere near ideal. And if you look at where we are at 1 year, it actually gets worse. So 1 year after GDMT initiation, target dose achievement, which is represented in traffic light green, versus discontinuation, which is represented in traffic light red, you see far more green than red for every class of medication. And if you're questioning, as I did, well, how much of this is related to appropriate discontinuation of ACE and ARB for institution of ARNIs, that's actually represented by these thin blue lines that we see in ACE and ARB. And there are many reasons why patients may become intolerant to one or more of these drugs by the end of a year, and I don't have to talk to this audience about why. But I think that the take-home message from this slide is that the 4-drug combo, as impressive as it really isn't available to all of our patients all of the time. So what does that mean for our patients? When we look at their ubiquitous natural history cartoon, the highest activity for heart failure patients in terms of what happens to them, their symptoms and decompensations, is at the beginning and toward the end of life. And while with today's amazingly effective therapy, some patients may start on GMT and have near remission of symptoms, most eventually progress along the downward trend. Patients in that great in-between of not recovered or remitted and too well for advanced heart failure interventions remain symptom limited, class 2 and 3, and patients in these categories will suffer from debilitating symptoms and poor quality of life, as we know. 76% have difficulties with usual activities. A similar number have mobility issues. 24% struggle with self-care, which is also emotionally devastating, so it's not surprising to know that 50% suffer from anxiety or depression related to their limitations. And while no one questions that GDMT improves heart failure morbidity and mortality to a degree not even imagined 20 to 30 years ago, there are still gaps, opportunities, and more that we can do for our patients. So we look at quality of life, despite the fact that GDMT is so effective in reduction of mortality and the morbidity of heart failure hospitalization, is actually not as impressive when we look at actual quality of life. And as powerful a drug as the ARNI is, Entresto, in the Paradigm registrational trial, quality of life didn't actually improve. It's just that quality of life for patients on Entresto was less bad than quality of life for the patients on the active ACE comparator. When we look at exercise capacity, the benefit of GDMT is also quite modest. Now, CRT, another effective intervention, does offer robust benefits in terms of exercise tolerance as well as quality of life, but unfortunately, CRT is indicated in less than 30% of heart failure with reduced ejection fraction patients. And as we know, even for those patients for whom it's indicated, and by some analyses that number may be a lot lower, closer to 15 to 20%, and 30 to 40% of the patients who are implanted won't necessarily respond to the therapy. So where else can we look? So we've clearly enjoyed, and our patients have enjoyed, the benefits of neurohormonal modulation. What about neuromodulation? We know that the autonomic response in heart failure is abnormal. Afferent signaling from chemoreceptors, metaboreceptors, and the renal nerves all contribute to the vicious cycle of heart failure. And baroreflex control, highlighted in blue, is of particular significance because when you look at the baroreflex actually are the primary mechanism for autonomic modulation of the ANS in terms of sympathetic activation and RAS activation as it pertains to the heart and cardiovascular homeostasis. The downstream result of decreased baroreceptor signaling are adverse physiologic changes familiar to us all, such as increased heart rate, increased remodeling, increased renin secretion, and decreased diuresis, and inappropriate vasoconstriction. It's also known that the baroreflex activity is impaired in heart failure specifically, which results in the pathologic imbalance in sympathetic and parasympathetic tone that we're familiar with that underlies many of the symptoms, the worsening symptoms associated with heart failure. Now, the rationale for the Barostim device is that if the baroreceptors are essentially impaired by heart failure and activity is less than desirable, why not use Baroreflex activation to increase sensitivity and thereby decrease inappropriate sympathetic tone, increase parasympathetic tone, leading to a reduction in symptoms. So the device itself, the elements are a single carotid sinus lead that's implanted extravascularly to the carotid artery through a small incision in the neck, similar to the access used for an endarterectomy. The lead is tunneled over the clavicle and connected subcutaneously to a pulse generator, which is about the size of a normal pacemaker and is placed in a standard pacer pocket. Procedure takes about an hour or less, and most patients go home the same day, and there's no intravascular or intracardiac hardware, importantly. So I'm going to conclude with making a few points. One is that despite amazing contemporary GDMT, there's still treatment gaps in the treatment of our patients with heart failure. The patient tolerance of and ability to comply with GDMT is not ideal. And there's still excess mortality in this population, even in the face of complete GDMT. Exercise capacity and quality of life remain poor. And Baroreflex Activation Therapy is a unique opportunity to work through recalibration of sympathetic and parasympathetic activity in the autonomic nervous system. It's a novel option for patients with persistent class 2 to class 3 symptoms and a narrow QRS. And the safety and efficacy of Baroreflex activation is supported by randomized clinical trials with long-term follow-up. And I'm going to hand the mic over to my colleague, Dr. Howard, who's going to give you that data. Thank you.